I hope you enjoyed the workshop on tension band wiring. Improve the contact and stability between two ends of the bone, which is an old principle. Chanley initially popularized this principle by using Chanley's compression clamps for knee and ankle arthrodesis. He also used the compression screw in the hip. Further on, Danish from Belgium popularized the plating of long bones, followed by Bagbay and others. Since 1958, the AO group headed by Mueller has developed the principles and instruments and implants to use compression as a tool for fracture treatment. Coming to the biology of fracture healing, basically, if there is marked instability at the fracture site, there is failure of bridging callus and leading to non-union. In cases of nailings, there is minor instability, that is micromotion, and there is periosteal bridging callus. But when you do a plating of the bone, stable fixation, there is no micromotion, and there is primary bone healing, bone-to-bone healing. That is the Mueller's concept of osteal healing. As we all know, we have studied this. Hello? There is a fracture even with minimal amount of implant. So what are the types of compression? One is the static compression, which does not change with time, and dynamic compression with periodic and partial loading and unloading due to functional activity. Like you studied just now, tension band wiring and tension band plating was being done in the past. So what does compression do exactly? It resists local shear at the fracture site. Normally in a transverse fracture, there are torque forces acting at the fracture site. There are torque forces acting at the fracture site, and in oblique fracture, there are axial loading forces. Compression produces friction between the compressed surfaces and hence resists displacement of the fracture. Compression can be provided by various means. Compression can be provided by using a plate. Compression can be provided by using a screw. Compression can be provided by plate and screw. Compression using tension band principle. So what is interfragmentary compression by latch screw? Basically compression between two fragments with a screw where the threads engage only in one fragment. This is called interfragmentary compression by latch screw. Compression acts from within the fracture site. That the compression is within the fracture site as you see over here. What are the principles for latch screw? It can be achieved by a partially threaded screw or a fully threaded screw with proximal cortex being over-drilled. Proximal screw thread must not engage the bone. This is very important, that the proximal screw thread must not engage the bone. Threads should engage only the far cortex. In partially threaded screws, the threads must cross the fracture site to achieve the lag effect, and the screw head must be firmly abut to the proximal cortex of the bone. So, coming to the guidelines of insertion of latch screw, it is very important that the latch screw should be always inserted in a perpendicular direction to the fracture site. As you can see, if this is the oblique fracture, this should be at perpendicular 90 degrees to the fracture site. Any other angle, if you try to put the screw, your reduction will not be that stable, and you have all chances of losing the reduction as you go on tightening the screw. So this is an ideal way to put a latch screw in the perpendicular manner so that you can achieve maximum compression at the fracture site. If you see in this fracture, it has been passed straight, and then there can be a displacement of the fracture. And when you have long oblique spiral fractures, there are different guidelines. In multiplanar, you can pass, as the fracture goes around the bone, you can pass the compression screws along the bone in the perpendicular angles. So what are the steps for a good latch screw fixation? You must use a reduction clamp while achieving compression till the screw is inserted. Once you get your reduction, don't move your reduction clamp. Always pre-drill the distal cortex. Always over-drill the proximal cortex, and always tap the distal cortex completely. So these three steps are very important, that you pre-drill the distal cortex, over-drill the proximal cortex, and tap the distal cortex completely. Avoid removing and reinserting a latch screw. Otherwise your fixation will not be optimum. What are pitfalls of latch screw fixation? Latch screw offers only stability and not strength as fracture fixation. what can happen if you just put a lag screw? You have to always augment it with a neutralization plate. So once you put a lag screw, you have to always augment your fixation with the neutralization plate. Lag screws can be used for fixing the third fragment, which is always in complex fractures, and it also can be used for fixing long oblique spiral fractures. Lag screw principle can be applied to fixing metaphyseal fractures. There are some examples over here, as you can see in this tibia. It's a complex fracture of the tibia where there's the anterior cortex which is opened up, the medial condyle is fractured. There are 3 lag screws passed, and the reduction is absolutely beautiful. And this is the way lag screw principle can be applied. This is a lower end femur fracture with an oblique fracture, where again 2 lag screws has been passed and the neutralization plate has been applied. Similarly, a humerus spiral oblique fracture where lag screws, initially you hold the reduction and pass the lag screws and a neutralization plate is applied. Proximal humerus fracture, again a oblique fracture where lag screws hold the fracture in reduction and the neutralization plate is applied. So coming to axial compression with plate. So when you do a plating of the bone, you should apply the plate always to the tension surface of the bone. Pre-tensioning is done using the plate. Bone fragments should be in good contact circumferentially. Load sharing occurs between the bone and the plate. Principles of compression plate. Pre-bending of the plate is done with apex at the fracture site. You always, when you're doing a plating, you should always try to pre-bend the plate with the apex at the fracture site. So this, coming further, I'll explain how pre-bending works. Pre-bending should be done between the screw holes of the plate. The apex of the bend should be 2 mm away from the bone surface for ideal compression. And elastic recoil of the plastic deformation causes compression of the far cortex. Basically, when you pre-bend the plate and then apply screws from the middle of the plate, the elastic deformation causes compression of the far cortex. So rules of pre-bending: screws should be applied sequentially from the center to the periphery. So when you are using a pre-bent plate, you should start applying the screws first from the center and not from the periphery. Because if you apply from the periphery, then the cortex will open up. So you should start from the center and then go towards the periphery. These are the slides showing how proximal cortex opens out if distalmost screws are applied first. So this is showing how the cortex opens out, and this is a slide showing how the cortex opens out if the plate is applied without pre-bending. And in special situations like lower end tibia, there are pre-bent plates, or you can contour it and then apply it for good reduction. Then coming to the dynamic compression plate, compression is possible due to the special geometry of the screw holes, so that the screw head can slide along the slope of the screw hole. As you see in dynamic compression plate, there's a screw hole in the center and the screw can slide into this groove. Hence, compression is possible with the dynamic compression plate. Special drill guides are designed so that the screw positions are accurate for compression effect. Basically, there's a neutral drill guide and there's an eccentric drill guide. These drill guides should be used properly while you want to achieve compression in a dynamic compression plating. Advantages of a dynamic compression plate is that interfragmentary screw can be passed to the plate in case of oblique fractures to obtain maximum compression and stability. Basically, due to the geometry of the plate, you can, through the plate, pass an interfragmentary screw as there's a groove, and then you can get a good stable reduction. The screw direction can be changed 7 degrees side to side and 25 degrees up and down in the long axis of the plate. This is 7 degrees side to side and 25 degrees up and down in the long axis of the plate in a dynamic compression plate. The adverse effects of plating are impaired vascularity of bone due to excessive operative dissection and due to contact of the implant. There is stress shielding, cancellization of the cortex, and stress concentration on either end of the implant can be there. So coming to the limited contact dynamic compression plate, the structure, the undersurface of the limited contact LC-DCP is a structured undersurface where you can see that there is less of the metal part. The undercut screw, there are undercut screw holes, and it is trapezoid in cross section. Special drill guides are designed specific for LCDCP as well. This allows the screw to be fixed as an IFS up to 40 degrees angle. So in a normal DCP you can go 25 degrees angle, in a LCDCP you can go up to 40 degrees of angle to pass the screw. There are special screws which are also available as shaft screws, which can be used for IFS as an IFS with an LCDCP. In conclusion, compression is a valuable tool in the operative treatment of fractures. However, plating requires a large exposure and atraumatic surgical technique. Poor results are due to improper selection of cases, poor surgical technique, and lack of proper OT environment and instrumentation, leading to infection and implant failure. Thank you.